we discussed about this 85-year-old man who sustained fractured acetabulum about a couple of years ago, was reconstructed, ended up with avascular necrosis, painful limping, shortening of the leg. Now you can see the x-rays, current x-rays, where we have seen the both anterior column and posterior column, posterior wall reconstructed with trochanteric osteotomy, 2 screws, but there is a non-union of trochanter, and of course anterior column united. Posterior column looks okay, posterior wall looks okay, though there is a defect medially. We've seen CT scan as well as 3D printing. So what we have planned was to do a total hip replacement with the reconstruction of acetabulum, and you can see the post-op. I used the anterior posterior column reconstruction as a support as well as posterior wall, used a little bit of graft, and I thought we will use a cage, but there was no need for cage. I used a medial mesh so that when you are doing cementing, it won't come into the pelvis. So used a large metal backed cemented cup, that's a dual mobility cup, and standard uncemented stem with a standard head. The reason for dual mobility is because post-traumatic, especially post-acetabular reconstruction, especially at that age, the dislocation rate is a little high. So it's safer to use a dual mobility cup. But one important factor is if acetabular fixation is not good, if it is not sound, if it's a dual mobility cup, what happens? The entire cup can pulled off because there is good coupling of the head with the cup. So you have to be very careful. You should have a good fixation of the acetabular cup, which you can see here, cement all around, and very nice reconstruction. Now you can see the leg lengths reasonably restored, and a good orientation of the cup and the stem. Previously we used to use very thick stems, but you don't have to use. Once you put a stem and get the reasonable rotational stability, I think you can accept. This was a corail stem size 12, which was satisfactory, and a trochanter, of course, reconstructed with thick suture, but very most important is the reconstruction of the abductor mechanism, and you can ignore the non-union as it is. We mobilized him on day 1, and he's doing well, and he's discharged home without significant pain.